Hi everyone, I'm Dr. Radhika, your anesthesia senior. So, today's topic is something really important, writing a long case. Now, why does this matter? Well, the long case carries 100 out of 400 marks in your exam. And honestly, it's the first impression you make on your examiner. So, yeah, it really counts. Shall we start writing it? 1. Demographic details. Start with the basics, right? The patient's name, age, occupation, and where they're from. Second, chief complaints in chronological order. What brought the patient here? And list them clearly in order. 3. History of present illness. Here, you explain each complaint, onset, when did it start, progression, how did it evolve, duration, how long, aggravating or relieving factors, what makes it better or worse, and for pain, don't forget Socrates, site, onset, character, radiation. You know the drill. 4. Negative history. This is where you shine. Rule out common things first, like infection, trauma, malignancy. Make sure you go system wise and rule out possible complications as well. 5. Past, medication, family, and personal history. Past history, anything relevant, surgeries, illnesses, medication, history, very important, especially in patients with diabetes or coronary artery disease. Family history, for example, thyroid issues. Personal history, appetite, weight loss, habits. 6. Summary, keep it cohesive. 7. GPE and examination. Start with vitals, pulse, BP, respiratory rate, pickle, pallor, icterus, cyanosis, clubbing, and so on. Local exam. If relevant, airway exam. Don't forget markers for difficult airway and Wilson's score. Summary. Here's your template. A dash patient of dash with dash comorbidities dash ASA grade presenting with dash. And on examination, dash findings were noted, suggestive of dash, has come for management. Illustration, obstructive jaundice. Let's take an example. Say Ashok, a 44-year-old farmer from Jaipur. Chief complaints, abdominal pain, 20 days, yellowish discoloration of eyes and urine, 10 days, generalized itching, 10 days, history of present illness, abdominal pain, insidious onset, gradually progressive, dull continuous, in the right upper quadrant, yellowish discoloration, lemon, yellow eyes noticed by his wife, yellowish urine by himself, generalized itching, disturbing his sleep but relieved on medication, associated weight loss like eating one roti instead of three, and loosening of clothes. Negative history, no history of fever, nausea, vomiting, blood transfusions, recent travel, or tattooing, black tarry stools, or coffee ground vomitus, increased sleepiness, vision loss, or bone pain. Examination. Vitals. Bradycardia noted. General examination. Pallor plus, icterus double plus, scratch marks. Abdominal exam. Liver and spleen expand. Airway exam. Wilson score to assess airway difficulty. Summary. A 44-year-old gentleman with no comorbidities. ASAI presented with abdominal pain, yellowish discoloration of eyes and urine, and generalized itching with weight loss. Examination shows pallor, icterus, plus plots, scratch marks, and bradycardia, suggestive of obstructive jaundice, possibly due to malignancy, and there are no features of hepatocellular failure. The patient is here for evaluation and management. My recommendation, I strongly suggest going through the ISR case discussion.